Hi, I'm Dr. Tigger, Distinguished Professor of Medical Toxicology, and this is Tig Talks, where we learn about different topics in toxicology in bite-sized, easily digestible snacks. As a cat, I enjoy snacks.
Today's topic is sympathomimetic toxidrome. This is our stimulant toxidrome, dealing mostly with norepinephrine, epinephrine, and our alpha and beta receptors. In the neuron, norepinephrine is released from vesicles into the synapse, where it is converted into epinephrine. From there, norepi and epi act on postsynaptic alpha and beta receptors to cause stimulant effects downstream. Both of these catecholamines act on both types of receptors, but norepinephrine acts more on alpha than beta receptors, whereas epinephrine acts more on beta receptors than alpha receptors. Now let's talk about some more specific causes of sympathomimetic toxicity. Causes can include the medications that we've talked about, dopamine, norepinephrine, and epinephrine, as well as drugs like cocaine, amphetamines including methamphetamine, MDMA, or ecstasy, and certain ADHD medications. Don't forget the methylxanthines, including caffeine and theophylline, which cause a lot of beta agonism. Another beta agonist is albuterol, and some special medications or drugs are PCP, ketamine, and dextromethorphan that have multiple effects, including sympathomimetic ones. There are cathinones that can cause this type of toxicity as well, including bath salts and bupropion, the only pharmaceutical cathinone. The clinical presentation is a result of having too many catecholamines on board. Vital signs will all be increased. In particular, the patient will be tachycardic, hypertensive, and hyperthermic. Hyperthermia is the most dangerous vital sign change, conferring an increased mortality risk. On exam, your patient will have diaphoretic skin. They'll have dilated pupils. However, they will not have blurry vision, which distinguishes the vision here from anticholinergic toxicity. And they will have increased CNS activity, resulting in agitated delirium. These patients may be angry or irritable. They may also exhibit tremors and even have seizures. Sometimes catnip makes me act a little sympathomimetic myself. Okay, back to the lesson. Potential sequelae of sympathomimetic toxicity include cardiac effects like acute coronary syndrome, so we want to make sure to order an EKG and probably a troponin. The patient may have a stroke, so it's important to do a good neuro exam, and sometimes we may want to obtain a head CT. And the patients will also be at risk for rhabdomyolysis, so it's important to order tests like creatine kinase, serum creatinine, and potassium levels. Now, let's talk about treatment. As a cat medical toxicologist, I always recommend benzos and supportive care. Our goals in treating our patient include treating the signs and symptoms, including the agitation, and then preventing the sequelae. And our third goal is to reverse the underlying cause. Benzos are going to be the mainstay of treatment with supportive care. Options for this include hydration with crystalloids, as well as temperature management, remembering that hyperthermia confers an increased mortality risk. Another good option is administration of sympatholytics like dexmedetomidine. These are centrally acting alpha-2 agonists that can help decrease the norepinephrine released from the nerves in your brain. Our titration endpoint for the sedatives in this patient is going to be nice gentle sleep with a RASS of 0 to -1 until they're able to metabolize their toxicant. This has been Sympathomimetic Toxicity, brought to you by Tig Talks. If you learned something today, please like and subscribe.